Sure. So there's several reasons for that statement. The first reason is that the donor-derived cell-free DNA appears to be a marker of injury, and that the donor-specific antibody is a marker of antibody against an antigen that may or may not be associated with injury. In fact, if you look at the original paper by Terasaki and Patel in the New England Journal of Medicine, I think it was in 1969, even people with a positive T cell cross match, 30%, I believe was the number, did just fine. So in fact, we know from some of the data, thanks to the cell-free DNA, but both with the this product and other products, that 50% of the time, the DSAs that were detected were not associated with an elevation in donor-derived cell-free DNA, and the patient's outcomes were fine. So thus, I think that the donor-derived cell-free DNA can be used in several ways to sort out harmful from non-harmful donor-specific antibody, infections such as BK, or other injury-producing events. So you might have an injury, but if the donor-derived cell-free DNA isn't elevated, that injury might not be that clinically important. The problem with DSA is also it's a very imprecise, non-quantitative test, and their various labs have various ways of looking at it. So should we use MFI, mean fluorescence intensity? Should we be using the titer of the antibody, especially with antibody-mediated rejection? That is not a commonly assessed level of the concentration of the donor-specific antibody, but it really ought to be, because if you're going to be using therapies such as plasmapheresis, if it goes away with one dilution, is it really important? And if it's not very intense, is it really important? So it's a very complicated test and to deal with. Oh yes, that's important. So that in fact we've published on this, and with respect to the use of checkpoint inhibitors and the use of donor-derived cell-free DNA, because the use of checkpoint inhibitors for treatment of cancer in transplant patients, renal transplant patients, is associated with about 50% of them having major rejection and loss of the allograft. Interestingly, it tends to be T-cell mediated rather than antibody-mediated rejection, but it tends to be severe and rapid. So we had looked at that to use cell-free DNA in developing our protocols to see as an early marker of when rejection might be recurring, and showed that the cell-free DNA in that scenario came up about 2 to 4 weeks before there was a clinical rejection. As this is important because most of then it relates to the study that was presented at the WTC, because the T-cell mediated rejections, the timing tended to be not the elevation of the donor-derived cell-free DNA did not occur as early as it did with antibody-mediated rejection. The importance of that is that the antibody-mediated rejection is a type of rejection that we don't really have an effective treatment for, or an effective way of monitoring how well it's responding. So, but the T-cell mediated rejection does. So I think that it's going to be useful it could be used routinely, and we'll talk about what are some of the barriers to its routine use. I think it could be. Well, I think it can, but designing those studies is very difficult. I've participated in a lot of studies over the years trying to figure out how to adjust immunosuppression. What I think this study shows really on a large scale, and thus for the first time, are a couple things regarding immune suppression. But interestingly, it's on the post-event immune suppression maybe utility than pre. I do think that there's a possibility of using this and finding if you are, and this has been published, that the AlloSure or the donor-derived cell-free DNA may be able to show you when a patient's immune system is quiescent. So you might use that to take a little bit more risk or by lowering the immune suppression. I think our field, the transplant, has in general given patients the highest tolerated dose rather than looking diligently to give the lowest dose that's effective. And part of it is having biomarkers that might be useful. I think that donor-derived cell-free DNA might be one of those to show when it's quiescent, continue to monitor, and change your course in case you need to augment the immune suppression. But I think what this study showed was an important thing on adjusting immune suppression. After you have an event like rejection, what happened? Well, what happened was the T-cell mediated rejection, the donor-derived cell-free DNA associated with T-cell mediated rejection went down with treatment. And it didn't go down with antibody-mediated treatment of antibody-mediated rejection, which gets back to something we know and which the Transplant Society consensus statement states clearly. There is no known effective treatment for antibody-mediated rejection. So the point is, why are we doing what we continue to do? The oft-quoted quotation from Einstein, to continue what you're doing when it doesn't work is insanity. So I think that that's one utility of it. I think it wasn't exactly unexpected, but what we just talked about, the utility and the importance of post-event monitoring. In general, I believe that donor-derived cell-free DNA has been monitored as a pre-event test. The second thing that I was really surprised about was how to interpret the relative change value. First of all, understanding that concept is important. So the relative change value basically was brought to my attention on a paper that I shared with Jonathan Bromberg, who is the first author of this paper, where it is more than the coefficient of variation. It's basically the test has certain variability. And when the test between testing at point A and point B, when that change exceeds 61%, that is beyond the biological variability. So that's the relative change value. Now, that's been hard for me practically on how to use that. If you have someone, say, who has a donor-derived cell-free DNA of 0.1 and it goes now to 0.4, that's way more than 61%. Is that important? I've kind of felt no, it's not. And I think this study shows how the relative change value is important when to use it. So it looked at the group of patients that had a donor-derived cell-free DNA level that was above 0.5%. So we normally think of 1% as the threshold, maybe 0.7, 0.5. But if that 0.5, there's a relative change value of 61%, then that was associated with worse outcomes. So if you go from, say, 0.3 to 0.52 or whatever the 61% is, that group that's important. So that was a surprise to me, a clarification. It's more than a subtle nuance. I think it's an important clinical finding. Yeah, so I think that the audience needs to realize this is a test, and tests need to be interpreted in light of the clinical situation. So sometimes you have results that just don't make sense. And what do we do when that happens? Well, what I do is usually repeat it. And if it still doesn't make sense, then I reach out to the people who know about this. And we've discovered some remarkable things about the technology that are teaching it more and more about the biology of rejection and donor-derived cell-free DNA. So ask for help if you don't understand it.